On this channel, we have covered a lot of ground when it comes to India. The military, the technology, the doctrine, the sheer scale of it, the economy, the infrastructure, the financial transformation happening at a pace that is genuinely difficult to keep up with. But today we are going somewhere different. Today we are looking at something that does not always make the headlines, but arguably should. Today we are talking about healthcare. 5 notable things India has achieved in healthcare. 5 things that show a country that is taking serious care of its people. And here is why this video needed to be made. In 2024, India was officially removed from the World Health Organization's high-burden, high-impact malaria list. This is the WHO, the world's leading health authority, formally recognizing that India had transformed its malaria situation so completely, so thoroughly, that it no longer belonged among the nations most devastated by the disease. More about this later. Before we get into it, a genuine thank you to every member who has joined and supported this channel. Your support really does mean a lot, and it keeps this going. If you are watching and you have not yet subscribed, that is another great way to support us. It helps more than you know. We are truly grateful for every one of you. Now, let's get into it. Number 1, malaria, how India drove a killer off its land. Let's start with a number, 1.17 million. That is the number of malaria cases recorded in India in 2015. Over 1 million people in a single year struck down by a disease carried by a mosquito. A disease that in many parts of the world is simply accepted as a permanent feature of life. Now hold that number, because by 2023, just 8 years later, that number had collapsed to approximately 227,000 cases. That is a reduction of more than 80% in 8 years. And the deaths? In 2015, 384 people died from malaria in India. By 2023, that number had fallen to 83. This is not an accident. This is not luck. This is the result of one of the most sustained and underappreciated public health campaigns in modern history. Millions of insecticide-treated bed nets were distributed, not left at warehouses for people to collect, but put directly into the hands of families in the most remote and underserved regions. Indoor spraying campaigns went village to village, district to district, disrupting breeding grounds and making the mosquitoes' environment as hostile as possible. But here is the part that most foreign observers miss. The secret weapon was not a drug. It was not a chemical. It was not technology shipped in from abroad. The secret weapon was people, an army of volunteers and community health workers who ensured that every family in every corner of every district had access to the services the government was delivering. These were not highly paid specialists. These were grassroots workers who knew their communities from birth. People who could explain, in the local language, with the trust that only comes from being one of your own, why the bed net mattered, why showing up mattered. This decentralized network was the backbone of everything India achieved in malaria reduction. Without it, the programs would have remained beautiful ideas on paper, and the world noticed. In 2024, India was removed from the World Health Organization's high-burden, high-impact malaria list. This is the list that tracks the countries where malaria is causing the most harm in the world. Being removed is not a formality. It is a formal acknowledgement from the world's leading health authority that India had transformed its malaria situation so dramatically it no longer belonged among the most devastated nations. Think about what that means. The decades of suffering that preceded this moment, the millions who were sick, the parents who lost children, the workers who lost months of their lives to fever. And then think about the fact that India looked at all of that and said, no more. That removal from the WHO's high burden list is not just a health statistic. It is a declaration. India telling the world, through the sheer weight of evidence, that it refuses to be defined by its struggles. Number 2, tuberculosis, racing against a disease the world has given up on. Now let's talk about a disease that most people in wealthy countries think belonged to the 19th century, tuberculosis. In much of the developed world, tuberculosis is something you read about in old novels, something the modern world with its antibiotics and hospitals left behind. Except it hasn't. Globally, tuberculosis still kills more than 1 million people every year. It remains one of the deadliest infectious diseases on the planet. And for years, India carried one of the heaviest tuberculosis burdens of any country in the world. Between 2015 and 2024, India reduced its tuberculosis incidence rate by 21%. To understand why that is remarkable, you need the comparison. During the same period, the global average rate of decline was approximately half of what India achieved. India declined at nearly double the global rate, double, in a country of over 1 billion people, with some of the most complex geographic and demographic challenges on Earth. So what did India actually do? India built the world's largest rapid diagnostic testing network for tuberculosis. Over 9,000 facilities where people could be rapidly tested, not waiting weeks for results, getting diagnosed quickly, so that treatment could begin quickly and transmission could be interrupted quickly. Speed matters enormously in tuberculosis control. Every week someone goes undiagnosed is a week they can infect others. India understood this and eliminated those delays at a scale without precedent. But the 9,000 facilities were only part of the story. India also deployed artificial intelligence-powered chest X-ray units to assist in screening. Not a pilot program in one city, a national strategy using AI to analyze X-rays and flag potential tuberculosis cases with speed and accuracy that human radiologists alone could not match at scale. A health worker in an understaffed district hospital now had an AI tool helping identify which patients needed further tuberculosis investigation. The accuracy of screening improved. Cases that might have been missed were caught earlier, and then those patients needed to be treated. Treating tuberculosis requires months of consistent medication. In communities where trust in formal healthcare is fragile, where people may not understand why they need to keep taking pills even when they feel better, having a trusted local health worker who follows up, who knocks on the door, who speaks your language and knows your name is the difference between success and failure. India built that support structure too. Number 3, the dialysis program. Kidney failure should not be a death sentence for the poor. Here is a question that most people in wealthy countries have never had to ask themselves. If your kidneys failed tomorrow, if the organs that filter your blood simply stopped working, could you afford to stay alive? In countries with strong public health care, this is almost theoretical. You go to a hospital. You receive dialysis, the mechanical process that cleans your blood 3 times a week, for hours each session, for the rest of your life or until you receive a transplant. It is expensive and demanding, but in a country with universal health care, it is done. You live. Now ask that same question where there is no universal coverage, where dialysis costs money families do not have, where being poor and having kidney failure means without intervention that you die. Not immediately, but slowly as toxins accumulate, as the body that kept you alive for decades gradually surrenders. For many families in India, particularly those below the poverty line, this was not hypothetical. A diagnosis of kidney failure was not a beginning of treatment. It was an announcement of a death sentence. The treatment existed. It was just out of reach. In 2016 and 2017, India launched a program that set out to change that. The Pradhan Mantri National Dialysis Program, a national effort to provide free or heavily subsidized dialysis to patients below the poverty line across the entire country. By 2026, this program operates across more than 750 districts, more than 1,700 centers, a network of dialysis facilities stretching from the largest cities to districts that would not, in any other context, be associated with access to high-technology medical care. For the families being served by this program, it is not a policy achievement. It is not a line item in a government report. It is the reason their mother is still alive. Think about the choices families were forced to make before this program existed. A father needs dialysis 3 times a week. Each session costs money the family does not have. Do you sell the house? Do you borrow money you will never repay? Do you watch him get sicker because the alternative is to bankrupt everyone around him? These are not abstract ethical dilemmas. These are actual choices actual families were making. The Pradhan Mantri National Dialysis Program said, no more. You do not have to make that choice. Come to a center, receive your treatment, Go home to your family. More than 1,700 centers. More than 750 districts. Number 4, maternal mortality. The rate at which women die during or after childbirth fell by more than 28% in India between 2014 and 2021. Since 1990, India's maternal mortality has declined by 86%. The global average decline over the same period was 48%. India's decline was nearly double the global average. Again, the government guaranteed free delivery services for women across the public health system. Free transportation so that women in remote areas could reach facilities. Free medicines during and after delivery, nutritional support, the entire experience of childbirth wrapped in a safety net that had simply not existed for so many women in previous generations. Number 5, the HPV campaign, protecting 12 million daughters in 90 days. Every year in India, more than 127,000 women are diagnosed with cervical cancer. Of those women, approximately 80,000 die. 80,000 deaths every year from a disease that is largely preventable. Cervical cancer is caused in the overwhelming majority of cases by a family of viruses called human papillomavirus, HPV. A vaccine exists that, when given to girls before they become sexually active, reduces the risk of cervical cancer by almost 90%. 90%. Think about what that means. Those 80,000 women who die every year. If a generation of girls had been vaccinated, many of those deaths would not have happened. They were preventable. They were always preventable. In 2026, India launched what has been described as the largest free HPV vaccination drive in recorded history. A 90-day campaign targeting approximately 12 million girls who are 14 years old. A single age cohort reached in a single coordinated national push. 12 million girls, 90 days, free. And this campaign is not the endpoint. It was designed as a gateway before the HPV vaccine is permanently integrated into India's universal immunization schedule, meaning every girl in India will have access to this protection as a standard part of growing up. India's Minister of Health, Jagat Prakash Nadda, stood at a World Health Organization press briefing and stated that India had joined the community of 160 countries in the global fight against cervical cancer. The Director General of the WHO, Dr. Tedros Adhanom Ghebreyesus, publicly commended India's leadership and recognized the country's progress toward the WHO's 90-70-90 elimination targets. Those targets require that by 2030, 90% of girls globally are vaccinated, 70% of women are screened, and 90% of those diagnosed receive treatment. India is moving toward all three simultaneously. On screening alone, the government had already screened 86 million women across 181,000 specialized health and wellness centers nationwide by the time the campaign launched. 86 million women screened. The logistics of the vaccination campaign, tracking 12 million individual immunizations, monitoring vaccine supplies across every district, are managed through India's own digital platform, the U-WIN system, built in India, capturing end-to-end records of every vaccination and monitoring stock levels to prevent shortages before they happen. Now look at the regional picture. Between 2016 and 2022, HPV vaccination coverage among girls across South and Southeast Asia hovered around 3%. 3%. By 2024, it had reached 14%, still too low, but moving. India's campaign targeting 12 million girls at once will accelerate that trajectory dramatically. And perhaps most powerfully, India is a country where reproductive health topics carry real social stigma. Getting 12 million families to consent to their daughters receiving this vaccine required not just logistics, it required education, trust building, community outreach, and the kind of sensitive communication that cannot be delivered from an office. It required going to families, explaining, listening, earning trust. The fact that 12 million girls will receive this protection is not just a medical achievement. It is a statement about what India believes its daughters are worth. The answer is everything. Number 6, the Indigenous MRI machine. India builds what the world said it couldn't. For a very long time, India's healthcare system relied overwhelmingly on imported medical technology. The most advanced hospital equipment, The diagnostic machines, the scanners, the surgical tools came from outside, from companies based in the United States, Germany, Japan, purchased at international prices, subject to foreign supply chains, reflecting a fundamental technological dependency that had not been broken. By some estimates, nearly 90% of the advanced medical equipment in Indian hospitals came from foreign sources. 90%. Think about what that means for a healthcare system trying to expand access across a country of 1.4 billion people. Every MRI machine in a government hospital had to be purchased from abroad. Every upgrade, every replacement part, every service contract, all of it in foreign currency. All of it reflecting a dependency the country had not yet overcome. MRI machines, the large scanners that hospitals use to create detailed images of organs and tissues, are among the most technically complex pieces of medical equipment in existence. They require superconducting magnets, sophisticated computing systems, highly specialized engineering knowledge. For years, the conventional wisdom was that India would simply have to keep buying them from abroad. Conventional wisdom was wrong. A company based in Bengaluru, the city synonymous with India's technological ambitions, called Voxel Grids, achieved something that had never been done in India's history. Working with major industry partners, drawing on engineering talent and research capacity that India has spent decades cultivating, Voxel Grids developed India's first fully indigenous MRI machine. India's first homegrown MRI machine, designed in India, built in India, using Indian engineering, Indian innovation, and the vision of an Indian company. The significance extends far beyond one machine. It is proof, tangible, undeniable, functional proof, that India can build the most complex medical technology in the world, that the country does not have to remain a permanent importer of someone else's innovation, and the implications for healthcare access are profound. One of the reasons MRI scanning has historically been expensive and inaccessible for large portions of India's population is that every machine had to be purchased from abroad at international prices. If India manufactures MRI machines domestically, the cost structure changes. The supply chain changes. More machines at lower cost means more hospitals equipped. More hospitals equipped means more patients accurately diagnosed. More accurate diagnoses mean better treatment outcomes. This is what technological self-reliance looks like in practice, not as a political slogan, as a concrete, working machine in a hospital, performing scans, producing images, helping doctors make decisions that save lives. And it was built by Indians, for India, in India. Behind this machine is not just engineering. Behind it is the frustration of decades of dependency. The determination of researchers told the technology was too complex to replicate locally. The ambition of a company that decided to prove those doubters wrong. The first indigenous MRI machine is not the end of something. It is the beginning. The first chapter in a story that, if India continues on this trajectory, will eventually see the country not just producing MRI machines for its own hospitals, but designing and exporting advanced medical technology to the world. India entering the field of indigenous advanced medical equipment manufacturing is one of the most consequential long-term developments in the country's healthcare story. It just hasn't been celebrated loudly enough yet. It is worth noting something that runs underneath all 5 of these achievements. Number 7, India's Swasth Bharat portal. India's healthcare transformation has not happened only in clinics and hospitals and dialysis centers and vaccination camps. It has happened in platforms and systems that track, coordinate, and make sense of a healthcare operation at a scale that would be impossible to manage with paper records alone. The U-WIN platform tracks vaccinations and manages supply chains for the HPV campaign. The AI-powered chest X-ray units screen tuberculosis cases faster than manual processes allow. The dialysis program tracks patients across 1,700 centers. And connecting much of this is the Swasth Bharat portal, launched with the support of Health Minister Jagat Prakash Nadda, a unified digital platform designed to connect India's multiple healthcare programs, reduce data duplication, and enable smarter decision-making across the entire system. Built in compliance with the Ayushman Bharat digital mission, it enables seamless data exchange between different healthcare programs and institutions, In practical terms, this means a patient visiting a primary health center in a rural district is not starting from zero every time. Their records travel with them, their vaccination history is accessible, their conditions are documented. The health workers serving them have a complete picture, not a fragmented one. Building a unified digital health platform for 1.4 billion people across hundreds of programs, thousands of institutions, dozens of languages, enormous variation in connectivity is an engineering challenge of massive proportions. India is attempting it anyway. Every vaccination recorded, with imperfect resources and enormous challenges ahead, but building it nonetheless. There is a story that circulated on social media not long ago. A German content creator was visiting Surat, one of India's fastest growing cities, when a street dog bit him. It was the kind of moment that could ruin a trip, the kind of thing that, in a foreign country, can spiral quickly into panic. He went to a government hospital, and what he found there stopped him cold. Not because it was bad, because it wasn't what he expected. He was seen quickly. The wound was cleaned and treated. He received the necessary post-exposure care. And when it was over, when the paperwork was done and the care was delivered, he was not handed a bill that would drain his travel savings or send him scrambling to call his insurance provider back home. The treatment was free. He made a video about it. He thanked the staff. He described the hospital as clean and efficient. And then he said something that stuck, that in Germany, a foreign visitor receiving that level of acute care would likely have paid significantly for it, possibly hundreds of euros, possibly more. In India, a stranger from another continent walked into a public hospital and walked out having received complete care at no cost. That video spread, and the comments section filled up with people from Europe, from North America, from across the world, expressing genuine surprise. They should not have been surprised. But the world has a story about Indian healthcare that it has been telling for a long time. A story about overcrowding, about overwhelmed systems, about the difficulties of delivering care to 1.4 billion people. And that story, while not entirely without basis, leaves out something essential. It leaves out what actually happens when you walk through the door. Walk into a government hospital in almost any Indian city. In many districts, you do not need an appointment. You do not need to call ahead. You do not need to explain to a receptionist why you believe your condition warrants being seen today, rather than in 6 weeks. You walk in, you register, you wait. Sometimes for a while, yes, but you are seen. This is not a minor thing. In the United Kingdom, the average wait for a GP appointment stretches into days, sometimes weeks. In Canada, emergency departments run on wait times that can extend for hours, even for cases considered non-critical. In the United States, the question of whether you can afford to be seen at all is one that millions of people ask themselves every day and answer by not going. India has not solved every problem in its healthcare system. No honest account would claim otherwise. But India has built something that the world rarely acknowledges: a walk-in culture, a system where access, at its baseline, does not require negotiating an administrative obstacle course before you can speak to a professional. For a foreign traveler, like David in Surat, this is startling. For an Indian family in a rural district who needs their child seen urgently, it is simply how life works. And that accessibility, that presumption of entry, is something countries with far more resources have not always managed to deliver. Then there is the question of cost. A routine consultation with a doctor in India, in a private clinic, not even a government facility, might cost the equivalent of a few dollars. Diagnostic tests that in the United States can run into hundreds, sometimes thousands, cost a fraction of that here. An MRI scan that in Germany might require weeks of waiting and a significant co-payment can often be scheduled within days in India at a price that is, by Western standards, almost incomprehensible. Medical tourism exists for a reason. Every year, hundreds of thousands of people travel to India specifically for healthcare. Cardiac surgeries, cancer treatments, joint replacements, complex spinal procedures. They come from the United States. They come from the United Kingdom. They come from the Middle East, from Africa, from Southeast Asia. They come because the quality is real. And because the cost, at Indian prices, is a fraction of what the same procedure would cost at home. A cardiac bypass surgery in the United States can cost well over $100,000. In India, the same procedure, performed by a cardiologist with equivalent or superior training, in a hospital with modern equipment and rigorous standards, costs a fraction of that. Not slightly less. A fraction. This is not a compromise. It is not medical care at a discount in exchange for lower standards. Indian cardiologists train hard. Indian oncologists study long. The doctors filling these hospitals are not lesser versions of their counterparts abroad. Many of them did their advanced training in the same institutions as those counterparts. Some of them came back from those institutions, from London, from Boston, from Toronto, specifically to practice at home. And the sheer density of the system is something that rarely gets acknowledged. In almost every Indian city, not just the major metros, but second and third tier cities across the country, the concentration of hospitals, clinics, diagnostic centers, and pharmacies is remarkable. You are rarely far from a pharmacy. You are rarely far from a diagnostic lab where blood work can be processed same day. The infrastructure of everyday healthcare is woven into the urban fabric in a way that many visitors from countries with far fewer facilities find quietly astonishing. Government hospitals serve as a true safety net, not a theoretical one. The care provided is real. The medicines are real. The staff are real people who chose these professions not because they promised wealth, but because they believed in what they were doing. A nurse working a 12-hour shift in a district government hospital, managing a caseload that would overwhelm a ward in a well-resourced Western facility, is doing something that deserves recognition far beyond what it usually receives. David's video from Surat was not about a miracle. It was about something quieter, and in some ways more remarkable. It was about a system that, when a stranger needed help, helped him, without hesitation, without a form to determine whether he qualified, without a bill at the end. India has spent decades building that capacity. Not perfectly, not without cost, not without the strains that come with serving one of the largest populations on Earth. But the building has been real. The world has a story about Indian healthcare. India has been quietly writing a different one. It is time the world started reading it.